Yes, ma'am, we are live now. We can start.
Good evening, everyone. A very warm welcome to all of you in this next series of ACP India Case Files, which is a John Toker Evergreen Award-winning series and an excellent medium of updating all the early career physicians. We have two very interesting sessions and a panel of experts from India and USA who will enlighten us all today. But first, please join me in welcoming the Governor of ACP India chapter, Dr. Anuj Maheshwari, sir, who is the backbone of this series. Anuj, I would like to invite sir to say a few words.
Thank you. Thank you, Preeti, and welcome and greetings to all ACP members, India chapter, as well as abroad, those who are listening us. And I am very much sure that we are coming up with a very exciting program this time again. Dr. Mukhya Prana Prabhu is going to give you a case presentation. And the idea of this program, making a case presentation by a senior professor, is that just to make learning to the youngsters how to do the things and how to make the things in the best possible excellent manner. I believe that no better could be today for this purpose except Dr. Mukhya Prana Prabhu, and he has himself offered to join this program for this clinical case discussion. And good thing is that another senior professor, Dr. Swati Srivastava, is going to moderate the session. And apart from that, what the wonderful thing we are going to have this evening, that is a learning for our youngsters, learning for our residents, learning for our students, how to write a case report. We are going to have a very elaborated program on this, how to write case reports, how to write chapters, and how to write reviews, how to write articles or original articles in due course of the time, maybe in the next month. But this is a primer of that program. You can say that when we shall be having a small discussion on how to write the case report and how can it be written in a best possible manner so that it can attract the publication. So with these words, without taking much time, over to the moderator of the program, Dr. Swati Srivastava. If Amit would like to say something, Amit, you can say.
Thank you, sir, for the kind words for our ACP India case files and welcoming all our esteemed guests today. And without any further delay, I will request Dr. Preeti to introduce Dr. Swati Srivastava as a moderator.
Now I invite Dr. Swati Srivastava, Professor, SMS Medical College, Jaipur, who will be our moderator for today's session. Please share ma'am's slide. Ma'am is working as Professor and Unit Head, SMS Medical College, Jaipur. She is trained in Endocrine Technology and Application, Fellow in Diabetes Management from CMC Vellore. Ma'am is the Chief Consultant of Dr. Swati's Diabetes, Thyroid and Metabolic Clinic. She's a member Research Review Board, SMS Medical College, member Advisory Council, ACP India Chapter, member ACE Diabetes, Thyroid Disease State Network. She has lots of awards, 14 awards and orations, and has large number of publications in peer-reviewed journals, paper publications, and chapters in book. I now invite ma'am over to Dr. Swati, ma'am.
Thank you very much, Dr. Preeti, for that kind introduction. And thank you, Dr. Anuj Maheshwari, sir, for this leading us through so many wonderful programs. Thanks to Amit Gupta also, and I welcome you all also. As we begin the program today, as Dr. Maheshwari said, we have two very interesting programs. Out of that, the first being an interesting case presentation. So can we have the slide for the presenter, Dr. Mukhya Prana Prabhu, please? So it's an interesting case by Professor Dr. Mukhya Prana Prabhu. He is a professor of medicine and unit head at Kasturba Medical College, Manipal. And he is also working as an academic coordinator for International Medical Student Exchange Program at Maastricht University, Netherlands. He's a voluntary faculty as well at the Assistant Professor of Family Medicine, University of Kentucky, USA. He has a special interest in type 2 diabetes, lipidology, infectious disease, hypertension, immunology, and medical education. Being a life member of important associations, he has a large number of research publications and he's a mentor to many students. He has received awards, including the ACP India Educator Award 2021 and the Corona Savior Award again 2021. He is a scientific editor to some important journals and has several conference presentations and publications. With that, I invite Dr. Mukyapran Prabhu to kindly start with your case presentation.
Can I share my slides now, madam? Good evening, everyone. And at the outset, I would like to thank Professor Anuj Maheshwari for such a wonderful series of ACP case files as for the, what you say, young and early career physicians. Is my slides visible?
Yes, your slides are visible, but you have to put them in the...
I will do that. I just first put the slides visible and then I will put it in a slideshow mode. Yeah. Is it in the slideshow mode? Visible?
Yes, that's right.
Yes. Yeah. So, good evening, everybody. And at the outset, I would like to thank Professor Anuj Maheshwari, sir, our esteemed Governor ACP, for starting this series. And it's very important for early career physician to start research in the form of writing case sheets. And he has got the idea of start presenting case by a professor. That's a very good idea. And our Dr. Amit Gupta, who is looking after such a wonderful case series for the last more than 1.5 years. And Professor Swati Gupta for a nice introduction, and my esteemed friend from US and Dr. Preeti for giving me this opportunity to present a case. This is an interesting case of chronic pain abdomen. It was a roller coaster ride for the patient, for us also. I thought it's interesting to present, so I requested Amit Gupta, shall I present it? He immediately agreed and gave me this opportunity. So this is a very interesting case for a young man with a chronic pain abdomen. So at the first, I would like to start with William Masler, who is considered father of modern medicine. He said, medicine is the science of uncertainty and art of probability. We learned it very well in COVID pandemic. And after the pandemic, we had this case teaching us a lot of lessons. So there are so many uncertainties in medicine and we have to learn new things each day. Let me go to the case presentation. Shall I proceed with the case, madam? I will go.
Sure, please.
Yeah. So this is a case of chronic pain abdomen and weight loss in a diabetic. He was admitted 5 times. 1 time outside the hospital in local place, Shumagga, and 4 admissions in our Kasturba Medical College Hospital. He is a 39-year-old male hailing from Shumagga, nearby place. He was by farmer by occupation. His disease started in the form of his roller coaster started with the detection of diabetes about 2 to 3 months back, when he was started on oral hypoglycemic agents, glimepiride and metformin, and he was also found to have vitamin B12 deficiency. He was started on treatment. And then he started developing pain abdomen for the 3 months. Then again, slowly over a period of time, he started losing appetite and weight loss, and fatigue was another complaint, which was there for 2 months. For this patient complaints, he went to an outside hospital as a routine anywhere. They did a routine investigation and they went ahead with the upper GI-scopy, which showed esophageal candidiasis, and CECT abdomen was done. There was a long segment mucosal thickness involving the distal ileocecal junction, ascending colon and prominent vessels. It was reported as a Coombs sign positive, suggestive of inflammatory bowel disease. And HRCT thorax was done. There were some fibrotic opacities in bilateral upper jaw. And colonoscopy was also done. Pancolitis was there. And biopsy was done. But they could not come to any conclusion. They referred it to us, to Manipal, saying that there is possibility of inflammatory bowel disease as a complaint. So coming back to summary, he had a chief complaint of abdominal pain for 3 months. And outside, CT scan showed long segment colonic thickening, which was confirmed by a colonoscopy. He was asymptomatic 3 months back. His abdominal pain was chronic 3 months. It was a dull aching pain all over the abdomen, spreading intermittent like colicky pain and which was non-radiating. There were no aggravating and relieving factors. He had loss of appetite, significant loss of appetite for the 2 weeks before coming, and again 2 months totally. Also, he had lost significant weight loss, about 5 to 6 kgs in 3 months. And there was a fatigue and breathlessness. Because of that, immediately the outside hospital referred the patient to us because his saturation was started falling. If you take a past history about pain abdomen, there was no history of nausea, there was no vomiting, there was no diarrhea or constipation, there was no history of jaundice, no history of cough, no history of fever, no history of trauma to the abdomen, there was no history of joint pain, ulcers, skin rash, skin lesions, hematuria, frothy urine, or epistaxis and skin ulcer. Then we took a detailed history, past history, which was, we knew it was a diabetic and oral hypoglycemic agent. But what we did is history, we got one more history. He had a minor trauma to his eye, and there was a decrease in vision. Initially left eye, then he went to ophthalmologist. They diagnosed it as an anterior ischemic optic neuropathy, probably non-arterial, they thought, and they gave a high dose of steroids. Methylprednisolone was given 1 gram for 3 days. And 1 milligram per kg prednisolone was continued. He was also started on aspirin. And he was, because of the pain abdomen, outside they did an endoscopy. There was candidiasis. He was started on fluconazole. And there was no previous history of medical or surgical comorbidities. Personal history, he was a vegetarian by diet. There was no history of alcohol consumption, non-smoker. There was no history of any high-risk behavior. There was no significant history or similar history in the family. This was the history which he was brought to the Kasturba Hospital emergency with the fatigue, worsening, and breathlessness for the last few days. At the time of clinical examination in emergency ward, patient was conscious. He was oriented to time, place, and person. His vitals were stable. His saturation was slightly low at 91% at room air. He didn't have any oral ulcers, malar rash, or arthritis. His abdomen was mildly distended. There was no guarding, no rigidity, no organomegaly, no free fluid, and bowel sounds were present. His respiratory examination, he had some decreased breath sounds over the right side, infrascapular and infraaxillary area, and few crepitations in the same area. Cardiac examination was normal. Neurological examination was normal at this point of time when he was came to admission. So we, again, it was referred case. We had seen the CECT of abdomen done outside. There was long segment mucosal thickening involving the distal ileocolic junction, ascending colon with prominent vessels. It was reported as probably suggestive of inflammatory bowel disease. And he had also CT chest done, few fibrotic opacities in both upper lobes and basal segment. And upper GI scopy was done. There was also candidiasis. And colonoscopy was also done, and biopsy reports were not available. Colonoscopy showed pancolitis involving even ileum. So histopathology reports was not available. And he was referred to Kasturba Hospital, Manipal, with a diagnosis of possibility of Crohn's disease or intestinal tuberculosis for further management. So patient, here we have a case of chronic pain abdomen. Patient has got a chronic pain abdomen. We thought that possibility, like any routine cases with a pain, but he didn't have fever. Tuberculosis is one possibility. Non-infectious causes like outside diagnosed Crohn's disease or ulcerative colitis. Malignancy is another thing which we thought, because the patient had long segment infiltration by thickening of the colon, and GI malignancy was also possible. Since he had some inflammatory changes, vasculitis is another thing was considered. Chronic pain abdomen, acid peptic disease, chronic pancreatitis, cholelithiasis, renal calcuria, all were kept in possibility, but the patient had a CT scan. So our focus was on Crohn's disease and tuberculosis. Other medical causes like patient being diabetic, diabetic ketoacidosis, porphyria, lead poisoning, psychogenic pain abdomen were all considered, but possibilities were less likely because patient was having documented lesion in the CT scan and colonoscopy had already been done. So anybody wants to comment at this stage, they can go ahead, or shall I proceed, madam?
I think we can proceed further.
Yeah.
Dr. Shanu,
Yeah.
anyone wants to say anything right now?
Because we will have about 20 minutes presentation. No? That's why I thought we will.
We
yeah.
may proceed. We will proceed.
Yeah. So patient was first time, I had told already, he was admitted 4 times. This was the first admission. His hemoglobin was okay, 11.8. He had some eosinophilia, which you can see at 13%. There were 10% bands, platelets were normal, ESR was normal. And he was admitted for about 10 days. His renal functions were normal, liver functions were normal. But what you can notice that he had a significant hypoalbuminemia. And his sugar was high, he is a diabetic, but glyco-HP was not very high, to say uncontrolled diabetes was 7.8, but CRP was grossly elevated 240. His vitamin B12 levels were more, he was already on treatment. Amylase lipase was normal, TSH was normal, cortisol was normal. But only other finding which was abnormal was he had a slight hyponatremia, 128. Again, first admission, this is what outside CT biopsy had been done. We collected the biopsy slides. It was reported as an active inflammation with histiocytic granulomas. So we thought that possibility of Crohn's disease as the first possibility. We took a GEC consultation. They suggested to repeat the colonoscopy to come to definite conclusion. Based on this slide, we can't give any granulomas are there. So they suggested, but patient was not willing to undergo one more colonoscopy immediately. Gastroenterologist suggested to add mesocol. We added it is for inflammatory bowel disease. We continued his fluconazole for esophageal candidiasis. And again, the slides for he had a sputum, some sputum, gram stain was negative, AFB was negative, but his CT scan showed some upper lobe infiltration. We still thought that it is a possibility of tuberculosis causing lung involvement and also colonic involvement. We went ahead with the bronchoscopy this time. Bronchoscopic fluid was sent for AFB, gene expert, gram stain. AFB was negative, gene expert for tuberculosis was negative. But surprisingly for us, ball fluid grew E. coli, gram negative organism, which is not a common organism from respiratory tract. But still patient was having a high CRP. He was not looking well. We changed our antibiotic from piperacillin to meropenem. We had already was on piperacillin from outside hospital. Clinically, he was looking better. Complaints were subsiding. He wanted a discharge. We discharged him with a request to continue meropenem for at least for 1 more week and fluconazole for some more day. We thought that steroids were not required. We stopped the steroids and stopped it. We put him on long-acting insulin and oral hypoglycemic agent. We added DPP-4 inhibitor along with the glimepiride and metformin. So he was discharged on 27th October 2022. So these were the first X-ray, which you can see there are some infiltrates in the lung upper lobe. When you think that in our India, we first think possibility of tuberculosis. And again, CT scan showed some infiltrates. And when at the time of discharge after treated with meropenem, his chest X-ray almost became normal. So then he went back and came back within next 5 days. That is on 1st November, he came back. This time, again, abdominal pain, there was a more significant, and fatigue was another prominent symptom. This time he had 1 to 2 episodes of loose stools 1 or 2 days before. We convinced the patient, all these admissions are in the ward only. He convinced the patient to undergo colonoscopy. This time gastroenterologist went ahead with the colonoscopy. There was a colonic slough covered with ulcers, multiple ulcers. They thought it's an infective bar inflammatory. Their possibility first being a Crohn's disease. Biopsy was taken from multiple areas from the rectum and also ileocecal junction, colon, and anti-Saccharomyces cerevisiae antibodies were asked to be sent. We sent it. But this time he started developing pancytopenia. So we thought, is it due to sepsis induced, or is it a disseminated disease, or it was due to mesocol? We have started as a possibility of IBD. So bone marrow was another option we thought this time. And he started developing persistent hyponatremia, hypocalcemia, and hypoalbuminemia went on down. So albumin started falling up to 1.5. He started developing pedal edema. He started becoming bedridden. And he started developing a right lower limb swelling and redness. We thought it is a cellulitis, but Doppler was suggestive of deep vein thrombosis. So in hospital, he developed shortness of breath. We went ahead with the CTPA. it showed pulmonary thromboembolism. We started him on anticoagulation. That time his platelets was around 1 lakh. So we could start the heparin. Then we changed it to rivaroxaban. Then he started developing fever spikes, blood cultures, inflammatory parameters were sent. There was a future suggestive of severe sepsis. By the time colonoscopy we got, it as I told, colonic slough covered with multiple ulcers, probably infective, more probably is it inflammatory, was what gastroenterologist thought. There was multiple ulcers in the ileum, cecal ulcers, and even multiple areas in the colon. So these are the investigations done in the second admission. If you see that still the organs were very well, but there was, all the reports were normal, but there was significant hypoalbuminemia and sodium started falling. Calcium was 5.8, corrected calcium was usually around 8. HbA1c had increased. Platelets had started falling again when we were giving that time. It came to 57 case. And again, he had iron deficiency anemia, but with increased ferritin, with the TSAT being low. We thought that is there any macrophage activation or hemophagocytic syndrome? Triglycerides were not raised. LDH was high, and there was a ferritin inflammatory markers were high. Meanwhile, he had a significant tachycardia. Thought it was due to pulmonary embolism. TROP was negative, pro-BNP was negative, and D-dimer was positive. So I think at that point of time, patient was falling very sick. Patient persistent to have hyponatremia. He was not able to tolerate anything orally. We had a tough time in controlling his hypocalcemia. We were giving daily albumin infusion, and he stopped eating also. He developed paralytic ileus, and he started having a gastric recurrence. So at this point of time, patient became bedbound, and that time we also noticed that he had a DVT, pulmonary embolism. We had to shift him to HDU. And again, bone marrow cultures and blood culture came. It was a gram-negative sepsis. Burgdorferi cepacia was isolated. Sensitive to meropenem, we started. Along with the septron, thought there was some pancytopenia. We could control it with this thing, and started then. And again, blood culture grew MDR Acinetobacter. We thought that whatever we were giving was not sufficient. We gave a molimixin. Anti-Saccharomyces cerevisiae antibody came. It was mildly raised, suggestive of Crohn's disease. We had a lot of confusion at this point of time. Patient had a persistent hypocalcemia, hypoalbuminemia, even IV oral calcium supplementation. We were not able to maintain the calcium. Albumin transfusion was given almost once in 2 days, and he had a significant anasarca. We started having a low dose diuretics were added. Orally, he was not tolerating. Meanwhile, we thought there is any other autoimmune disease. ANA global and profile was sent. It was negative. ANCA was mildly positive, but when we sent a titer, it was negative. RA factor, anti-CCP was negative. HLA-B27 was sent because he had some backache that was positive. Fever workup for all the tropical fever, leptospirosis, scrub typhus, all those things were negative because he was in 2-3 hospital. Candida was sent, that was also negative. Brucella was another common infection, it was normal. We thought that whether he is immunosuppressed, CD3, CD4 counts were sent, it was also normal. Bone marrow aspiration, as I told, we did, it was growing Burgdorferi sepsis, but it was cytopenia due to peripheral destruction rather than any aplasia. Stool examination was sent, it was normal. Then we had he underwent a colonoscopy. We did a ileal or rectal biopsy, multiple gastroenterology biopsy was done. Here at this point, patient had a chronic abdominal pain, diabetes, he had received corticosteroid treatment, long segment colonic inflammation, pancolitis, malabsorption, iron, vitamin B12, vitamin D, significant hypoalbuminemia, and weight loss. So anybody wants to comment on this at this possibility? The story is not ending, but I'm just telling at this point it's very important. We got a biopsy done in our center. Anybody wants to comment, or should we proceed, madam?
I think we can proceed. We can discuss in the end.
Yeah. So we continued this thing. This was the colonoscopic picture or a biopsy picture. So we can see here, but I am not able to mark it here. Yeah. So it came as ileal biopsy, came as a granulomatous reaction to strongyloids, nematode larva. This is a invasive strongyloids was the biopsy report. CD3, CD4 counts are normal. Autoimmune workup, everything is negative except HLA positive. AFA workup negative. So it was reported as a colonic iloic Bellasi. Features are suggestive of granulomatous reaction to strongyloids larvae. Stool examination is reported. So we did immunoglobulin levels. All immunoglobulins were, instead of low, it was high. Stool examination was normal. So we took an infectious disease consultation. They told that it is a strongyloid hyperinfection syndrome with internal autoinfection and eosinophilia. That was mild eosinophilia with probable gram-negative sepsis, which we had already isolated. Malabsorption syndrome, pancytopenia due to hyperinfection due to strongyloid. We thought that we have won a battle, and initial X-ray with the shadows of eosinophilia was Loeffler syndrome, which had improved. We thought that we have achieved the diagnosis, patient is going to improve. So we diagnosed it as a strongyloid hyperinfection. We started giving him tablet albendazole ivermectin through the Rayleigh tube. The third day, Rayleigh tube stopped. Ileus, paralytic ileus improved. Patient was accepting liquids. Slowly, patient was started on anticoagulation. His thrombocytopenia also improved. At day 14, his paralytic ileus resolved, and he was discharged in a stable condition. Again, after a few days, he came back to the OPD. 3 weeks with multiple ulcers and raised lesions over the trunk, arms, thighs, and legs. Joint swelling, this time significant arthritis, right elbow and right wrist. We thought it's asymmetric oligoarthritis due to inflammatory bowel disease. Still, we had not thought it's not unlikely. First discharge and post-rupture lesions were present. And again, because he had significant past infection of gram-negative infections and other things, we thought it's pyoderma gangrenosis or streptococcal bacteremia, staphylococcal bacteremia. We went ahead with the skin biopsy. These are the lesions which were there all over the body, including trunk and also abdomen. Multiple raised lesions. Pus was coming out from these lesions. These lesions were sent for culture. Initial pulse cultures were sterile. Some inflammatory reaction was noted. In fact, IFD consultation was given. They thought that it could be Staphylococcus bacteremia, and linezolid was suggested by OPD, and he was given ceftriaxone injection, linezolid to be taken in local place. And again, his reports were normal, except you can see significant hypoalbuminemia, but his counts were raised and ESR was significantly raised. So we thought, is it infective endocarditis, vasculitis, IBD related, or atypical infection? Again, repeat echocardiogram, there was no vegetation. Ultrasound showed diffuse subcutaneous edema, stool caloprotect slightly elevated, blood cultures were sterile. Again, he went back, and within 1 week, he had to come back with a generalized weakness, diffuse generalized anasarca, facial puffiness. By the time we had sent some tissue swab, that culture staining for AFB came positive. MGH reports were awaited, and IFD opinion this time said that it is a diagnosis of non-tuberculous mycobacteria, which is a rapid grower. We started the patient on amikacinum, meropenem, linezolid, azithromycin as protocol. Skin biopsies came as granulomatous infection. GEC opinions are that suggested colonoscopy, but again, patient was not fit at this time. Surgery consultation was started. Dressings were done. Rheumatology consultation was thought. They thought it is IBD related arthritis. PET scan was suggested. But when we started a treatment with azithromycin, meropenem, and linezolid, patient started improving again. Pus, MTB not detected, but culture came positive for acid pus bacilli. This was reported as non-tuberculous mycobacteria, mycobacterium. Abscesses was grown in the culture. This is a atypical mycobacteria, which is a rapid grower from the skin lesions. So again, we thought that patient we got a diagnosis. At this point of time, he started improving and he started walking around. He was looking much better. But on 26th January, he started sudden onset of shortness of breath. He collapsed in the ward. We had to shift him to ICU. There was a respiratory failure, severe lactic acidosis. Again, inflammatory parameters were raised. He was shifted to ICU. He had developed hypotension, acute kidney injury. His blood again and ET grown Acinetobacter. We gave again polymyxin, but this time we failed. His thrombocytopenia again worsened. Patient developed massive GI bleed, and he succumbed to the illness. So it was a roller coaster ride for the patient, but for us also. So patient had final diagnosis. It was a strongyloid stercolis hyperinfection, disseminated mycobacterium abscess, atypical mycobacteria infection. He had multiple gram-negative infection, Acinetobacter, Burgdorferi sepsia. He had finally upper GI bleed, MODS, pulmonary embolism, type 2 diabetes, and he had a bilateral optic atrophy, which we probably don't know what it was. So we were sure that it was not inflammatory bowel disease, it was a strongyloid superinfection. Any comments in this time, or shall I go to the discussion part, madam?
I think here we can discuss somewhat, like this has been a very interesting, prolonged course disorder this patient had, and it's starting from the chronic infection, the chronic long segment colitis seen on the CT scan and the GI symptoms. Then coming on having a lot of super infections, having DVT, developing probably DIC, then all the features of malabsorption like hypocalcemia, hypoalbuminemia, and then recovering also, and then again coming up and on repeat biopsy showing these strongyloids. So this becomes very interesting as an important differential diagnosis of many a times we don't realize that why the patient has long segment colitis and the patient keeps on having chronic diarrhea. So these parasitic infections also have to be kept in mind. And then what is interesting, Dr. Mukhya, what I found was that later on he comes on to develop non-tubercular NTM abscesses also.
Yeah.
So that becomes very interesting, especially by the fact that we have stopped the immunosuppressing corticosteroids long time back. The patient has received a lot of treatment. He has improved also. Probably why then later on does he develop NTM abscesses?
Yeah,
Could it be possible that right from the beginning he had, because he was already immunosuppressed, he had
Yeah.
a particular infection in his body, probably because the ileocecal junction was involved? Probably was it a latent, we could not get into it, but could it be a tubercular right since the beginning?
I'll just tell this is just my acknowledgement, my residents who struggled through this case, IFD and all. I will come to this again point. So many departments were involved in treating this patient. So this is a strongyloid stercolis hyperinfection. When we diagnosed, we went through the search through the literature. This is from the NEGM image of the month, which showed that strongyloid stercolis hyperinfection. So if you see that, immunosuppression is a trigger for hyperinflammatory syndromes due to strongyloid stercolis. Particularly in this case, it's from the membranous nephropathy when the steroids were started. This was from the journal 2020. And there are so many case reports. We were giving a lot of steroids in COVID time. When you see that American journal, there was an article, disseminated strongyloidosis in a patient with COVID-19, strongyloid infection manifested immunosuppressive for SARS-CoV-2. What was the point? What madam has risen? That was he immunocompromised? We went through all the possible. There is a T-cell immunity problem, CD4 was normal, immunoglobulin problems, all were normal. What he had probably when the corticosteroids were given, that was a trigger for this auto-infection. When the auto-infection occurred, there was a long segment colonic involvement, malabsorption started. Malabsorption, and again he was immunosuppressed. He started developing gram. His immunity never recovered. That's what I thought. Because whatever infection, whatever the literature is, all these patients have succumbed. When there is a strongyloid superinfection, all the patient mortality is more than 80%. We thought that we have won the battle, but it taught us that it is such a immunosuppression which caused this parasite. He could never recover. That's what we thought. And again, Mycobacterium atypicus is there in all our water, tap water and all. And again, it could be a hospital-acquired infection, but what is unusual is that he had all over disseminated. That is suggestive of that his immunosuppression was probably continuing, and it was not in one site, IV, cannula site, or abscess site, or anywhere. It was throughout the body. So this another thing is that what made us a lot of confusion is it a Crohn's disease? This is a case report which is published in Pathology Journal. Strongyloid colitis is a harmful mimicker of inflammatory bowel disease. There you give the steroids, again, patient may become more sick, and ultimately this that patient also expire. All this patient, whatever I see, 80% of them succumb. This patient, initially we thought that we have won the battle, but it was not. So I'm showing that risk factors, HTLV virus, HIV virus, both he didn't have. Malignancy, which he didn't have. Hypogamma-globulin was not there. Congenital immunodeficiencies, probably whatever we could do, it was not there. He was not alcoholic. If you see this next part, medical interventions, administration of corticosteroids, hyperinfection has developed in patient with COVID-treated corticosteroids, solid organ transplantation, all these things, okay. Another thing is that in the setting of hyperinfection syndrome, peripheral eosinophilia is usually absent. This patient, our patient didn't have much, only 13%. We had a lung shadows, which was lawfulness, which improved. Often there is a suppression of peripheral eosinophil levels, sometimes related to corticosteroid, concomitant bacterial infection. Presence of peripheral eosinophilia during hyperinfection appears to be, if it is there, it predicts a better prognosis. Our patient had only 12 to 13%. And this is a diagram from this thing, how it starts. It starts, it's a nematode, parasite, which we don't see it often. It is seen in highly immunocompromised patient. It enters through the skin and it enters through this larvae, then it goes through the lungs. And again, once it occurs, this is an auto-infection. This will go on continuous and patient will develop severe immunosuppression. This is what developed in our patient. So this is, again, I will not go into detail. This is called strongyloid stercolis hyperinfection. In immunocompromised patient, only it occurs, but the normal immunocompetent persons will usually clear it very fast, but we don't see it. Can be completely asymptomatic, sometimes vague abdominal pain, crampy burning pain, diarrhea, weight loss can be there. So if you can identify the larva, it's not easy. Stool examination is not very sensitive. IgG, LSA, we didn't have. Treatment for a normal infection is ivermectin, but our patient, we had to give ivermectin and albendazole for almost 2 to 3 weeks. Again, another thing is that did we give a long enough is another question. It has to be completely cleared. You have to give it long duration. Ivermectin we have given for 3 weeks in our patient. Another thing is the non-typical tubercular mycobacteria, which is Mycobacterium abscessus. Risk factors is a underlying lung disease, COPD, cystic fibrosis, HIV. Again, cough, shortness of breath, weight loss, but in skin infection, skin nodules, which our patient had, bone pains. But this again, it was not a localized infection. This was it could be from the contaminated equipment in the hospital, but this patient had a almost disseminated infection. We treated with azithromycin, amikacin, linezolid, but this organism is usually drug resistant. Azithromycin may not work for this patient. Again, this is what I told. Our organism was Mycobacter abscessus. It's the most pathogenic among rapid growing bacteria. It can cause pulmonary infection, post-traumatic wound infection. It is from the water. We don't know whether he went and had a bath outside or something, because he had better that time. So tolerance to saline medium, nitrate test is negative. Again, one more infection, I will not go into detail because of the time constraint, which we see commonly, gram-negative Burgdorferi, which has to be treated. It's from the Pseudomonas species. It has to be treated with meropenem and cotrimoxazole, which we treat for this patient. These are my references up to date from because this case, I thought it is very interesting for the young early career physicians, because parasites are there with us in India, Southeast Asia. This is a strongyloid, is a very, nematode, which can cause reinfection or auto-infection, can lead to hyperinfection, can lead to malabsorption. So these are what I told, some references. So what lessons, I thought we have won a battle, but it was not. Immunocompromised patients on corticosteroids, which comes with abdominal pain, keep a high index of suspicion of this parasitic infestation. And again, another thing which whenever I read about it, we use left and right steroids in medical practice. Be careful, because this patient, probably that was the trigger. He was all right for 39 years. And the diabetes was not so bad to cause him so much immunosuppression. And he didn't have HIV or any other this thing, what we could make out. Probably we didn't do the T-cell function and all. So, and again, we needed a lot of support, evidence-based medicine and teamwork, probably for patient care. But this patient we lost. Hopefully, next time we will be victorious. So, I want to end this with Louis Pasteur's statement. Gentlemen, it is the microbes who will have the last word, because COVID, we thought COVID has one, but again, our microbes are more intelligent than us. Thank you for the patient listening. And I would like to thank again Dr. Amit, Dr. Anuj Maheshwari sir, and Dr. Swati madam, and Dr. Preeti, and our foreign people for giving me opportunity to present. This case is open for discussion. Any case questions are there, I can solve them, because the time I thought it will be very precious.
Thank you very much, Dr. Mukhyaprand. That was a very interesting case, having very prolonged course, and you have discussed it also well, and you have investigated the patient also. I think with a lot of in properly throughout, in spite of so many recurrent admissions, and you tried your best. Strongyloids hyperinfection is something probably we do not think so often, and the message that you conveyed was very important, that parasitic infections also need to be kept in mind, especially when you are not able to come to a diagnosis, and very repeated just corticosteroid therapy also we have to be very careful about, especially because it can lead to such severe consequences. Thank you very much. That was a very interesting case, and I would invite our guests if they have any questions or any comments to say about the case. If anyone does, yes.
Dr. Prabhu, thank you for such an interesting presentation. Because of the type of format we're in, where you're presenting an interesting case, I think strongyloides was something I was thinking about early on, especially when the turning point was really when things got worse with steroids. That doesn't happen very often. Most people get better with steroids, right? So that's a clue that something's going wrong. But I wanted to ask you a question. What were your thoughts on this patient had P-ANCA positivity, correct?
Yeah, but that was a positive, but we did a titers. It was negative.
I see.
So some of these immune infections, some of the autoimmune titers can come positive. He was HLA-B27 positive. P-ANCA initially was positive, but we did titers negative. And that biopsy was 100% strongyloids. So we didn't have any diagnosis. But again, when we went through the literature, there are reports that IBD is the most great mimicker of this thing. Patient had abdominal pain and then some joint pain. And again, we gave us mesocol, whatever meso, this thing. That time he developed pancytopenia. And somehow each time we went one step ahead, we had to go back to the 2 steps. Finally, we thought he is all right. He succumbed to the gram-negative sepsis. So worms to worms to germs. So finally, probably Acinetobacter took his life.
Yeah.
And we were very shocked to find that he succumbed when he was all right. He was walking around in the ward. We didn't wanted to discharge him. That time he succumbed.
Oh, yeah, very unfortunate. Thank you.
Thank you very much. It's a very interesting case, and I'm sure we can go on with it, but then we have to move on because of paucity of time. Dr. Prabhu, thank you so much.
Thank you, madam.
And
I think this case was having so much of the big canvas where you can think about when you are starting your patient with a simplest kind of a problem, and then you can reach to the things which may not be ever expected, and quite unbelievable kind of the outcome. So this actually would be a learning for our postgraduates, that the clinical scenario may be anything, and it may be many a times beyond your expectations and beyond your imagination most of the time.
So I would just like
really,
to...
it has been a wonderful case, Dr. Mukhyaprand Prabhu, and we are grateful that you brought this with this.
So I would just like to make one comment here, Dr. Prabhu. Surgeons usually call any abdominal pain and abdominal disorder as Pandora's box.
Yeah.
But what presenting today is a Pandora's box for physicians also.
Yeah.
And I think it will be good learning for all of us. Thank you very much.
Thank you, sir. Thank you, Anuj Maheshwari, sir. Thank you, Shanu madam. Thank you, Swati. But it was a really wonderful case. I thought it's a wonderful experience for me also, because I had seen one strongyloids earlier. This strongyloids I thought I won the battle. I thought that I won the battle, but it was not. Because if you see that more than 80% of them succumb, that is another thing. This hyperinfection is so bad.
Absolutely.
Thanks for sharing this.
Absolutely, and that is the reason, such interesting cases which you present. I think that is the purpose of our second part of our program also, that the interesting cases should not just stop at being presented, they should be reported as well. And that is what we are going to talk about in our next part of the program with our esteemed guests, Dr. Shanu Gupta and Dr. Lauren Block, both have joined. So I think we can move on to the next part of the program. We will be having an interesting discussion discussion, panel discussion on how to write a case report. And for that, we have two very much eminent experts on the panel who will be discussing. We have with us Dr. Shanu Gupta. She is MD FACP and currently an associate professor of medicine at the Morsani College of Medicine, University of South Florida, Tampa. Her career, if I go to describe, her career in medical education started after she completed her internal medicine residency in 2011, when she took on the chief resident position, where her role was to develop, implement, and evaluate a didactic curriculum for the internal medicine residency. In addition, she developed a simulation lab, which worked mainly for procedural simulation. And subsequently, she served as an associate program director for internal medicine residency program at Mercy Hospital in Chicago. In 2014, she moved to academic hospital medicine, becoming the director of education for the division of hospital medicine at Rush University. In 2018, she moved on to Florida, where she is currently serving as director of faculty development in the Department of Medical Education at the University of South Florida, Morsani College of Medicine. Her role oversees the development, implementation, and evaluation of professional development programming for undergraduate medical education as well as graduate medical education faculty, Academy of Distinguished Educators as well. Her research interests include interdisciplinary communication, medical education, scholarship, and teaching, learning, assessment of clinical reasoning. She has worked with the AAMC through Directors of Clinical Skills and the Group of Educational Affairs, GEA, NBME, and Society of Hospital Medicine in developing curricular and assessment tools for clinical reasoning in undergraduate medical education and continuing professional development. Dr. Shanu Gupta has a significant contribution as an advisor to medical students, coach to resident trainees, and a peer mentor to colleagues in hospital medicine and medical education. We welcome you, Dr. Shanu Gupta, to the program. We have another very interesting, very illustrious panelist with us, Dr. Lauren Block. Can Ankitji please share the slide for introduction? Dr. Lauren Block is an assistant professor in the Institute of Health System Science, Feinstein Institute of Medical Research. She is also an assistant professor for Donald and Barbara Zucker School of Medicine at Hofstra, Northwell. Dr. Lauren Block is a general internist and clinician educator. Her research interests include trainee wellness, interprofessional education, curriculum development. She sees patients in primary care, percepts residents, and teaches epidemiology, communication, physical diagnosis, and clinical reasoning at the Zucker School of Medicine. Her research focus include mainly primary care perspectives on iStop, building awareness of healthcare teams among medical students and nurses, design of PD ultrasound curriculum for medical students, development of a patient experience module for medical students, resident attainment of patient-centered medical home EPAs, real patient as teachers of medical students, and evaluation of the impact, which is the improving patient access, care, and cost through training. Thank you very much for joining us, Dr. Lauren Block, and warm welcome to you. Welcoming both of our esteemed speakers and panelists for this panel discussions. As we know, that it's a common practice in medicine that when we come across any interesting case, like we just saw, an unusual presentation or a surprise twist to something when we see, then probably we should tell the rest of the world. And this is how we can continue our lifelong learning and aid a faster diagnosis and treatment options for our patients. Basically, a case report is a description of some important scientific observations that may be missed probably on a research trial or a clinical trial that may be undetectable, or an unreported, unrecognized disorder, some unusual twist coming through the clinical profile, some unusual response to any drug, some unusual, unique investigation modality, some unusual outcome. So starting with that, I welcome both of the esteemed panelists, and I start my first question with Dr. Shanu Gupta. How would you say what exactly would include the case report, and what is the need to publish it? Since we remember that our audience is basically all the young researchers. So from their point of view, what do we understand by a case report, and why should we go in to publish it and have it sent globally in the journals?
Thank you. Thanks for having us on this really interesting panel. This is something that both Lauren and I feel pretty strongly about, and I know I'm speaking for her, but we've done some work together in helping disseminate an understanding of why case reports are important. And the question you ask is a really good one. I think the pandemic kind of demonstrated to us really well why case reports were so important. I think we started teaching this work, the workshop that we'll be doing in April, we started teaching that way before the pandemic. And I think we hadn't recognized how important it would be to help people understand how to write those case reports. But I think for me, there's two big reasons why case reports are important. One is because although we talk about the different levels of evidence that exist to help us understand how to practice medicine, there is a base layer that forms the thought process to get to the pinnacle of the pyramid of research. And that base layer has to come from simple observations that we have day to day, right? So the observations that Dr. Prabhu provided on his patient not only demonstrate the in a rare and unusual disease, but also his thought process. How was he going about taking care of this patient? What were the clinical questions he was asking from his colleagues to be able to use the evidence that already exists to provide a diagnosis for this patient that he presented, a treatment plan for the patient that he presented, and then also to be able to talk about, the sad demise of this patient despite all of the efforts of the entire team that worked together to help take care of this patient. So it can be a really great way for us to educate ourselves on physiology, pathology, management tools. But I think the other piece that's really important to me is the mentorship part. So being able to use something like a simple case report, and I'm going to say simple, but I don't really mean simple, as a tool to help create a mentoring relationship with a junior colleague or a senior colleague. And then helping develop curiosity, because I think that's a really important basal skill for us as physicians. And I'm curious if Dr. Block has additional content to add to that.
Yeah, I think, thank you so much, Anu. So, and thank you so much for having us here. We're really honored to be here. We're speaking to you from the East Coast of the US, where it is currently morning, and I understand it's evening there. So it's really neat to be able to do this together. I think one of the things that we've tried to bring in, as Shanu mentioned, to our workshops is the fact that this can be an opportunity for teaching and an opportunity to demonstrate for some of our learners, whether medical students, residents, fellows, or even junior faculty, how to get involved in academic medicine. And I think case reports are, a very interesting, very time-limited way. I think undertaking a research project can be really time intensive, and for many of our trainees, they may not have that much time available. And I think case reports, are naturally draw us in, help us to understand the path that we're taking with this patient, what they may be going through, what similar patients with similar diagnoses may have gone through, and why this case is illustrative or interesting. And it can be a way for us as faculty members to bring in learners and sort of show them how to write up a case, how to present it, as Dr. Prabhu did so beautifully today, how to then take that to the next step of a conference at the regional or national level, and then even to publication, which can then help foster everyone's academic careers. And so the workshop that Shanu and I have done really focuses on how to engage learners to think about cases that they're seeing, to kind of discuss some interesting cases that we've seen with them, and then encourage the learners to think about what's interesting about the case, what else is known, do a literature review, and start to turn that interesting case into a conference presentation and eventually into a publication in a way that benefits us as the faculty, the learners, and ultimately our patients, which is everyone's goal.
Yeah, thank you very much, because that's a very important point both of you mentioned, is that stressed upon, is that it's an important exercise for us as well. And then as we go through it, probably it's a very important part, help for the rest of the world as well once it's published. So that's very interesting to know. But Dr. Lauren, I would like to ask you one thing, that many times, students, or we get cases who have some unusual presentations, they're more than one, so they are confused as to what do we understand by a case series and what do we understand by a case report. So is there any clear-cut difference between the two?
Yes, so I'd say a case report generally involves one patient. I think a common misconception is that it has to be a really unusual illness, or less commonly seen illness, sort of like Dr. Prabhu's case that he just presented. But I think the cases can be any even common diagnosis, common clinical condition that has an interesting diagnostic feature, an interesting feature on labs or imaging, an interesting risk factor, or an interesting aspect to management. So I think it is not just the zebras, as we say in medicine, but it can be a common case if it illustrates a novel pathophysiology or something that that may be interesting to us, or that we should be, but don't typically think about within medicine. And so we try to stress this with our learners, that it doesn't just need to be that rare condition that can make for an interesting case report. I think once we start to see more than one case, especially if this is a novel or emerging condition or even infectious disease, that then can become the impetus for a case series. And that was something that colleagues here at Northwell did and published in JAMA back in 2020, at the very beginning of the COVID pandemic, on the case series of patients that were treated at our hospital in New York at the very early on in the pandemic, and served to really illustrate for other colleagues nationally and even internationally exactly what we were seeing, how this virus was changing, and how management could be pursued for something that was relatively still unknown. And I think we relied on case series initially from China and some of the other places that had seen COVID initially. And then once the sort of surge of the pandemic hit us, we were then able to record these cases in a database and present them in a grouped fashion. And that really differentiates a case series from a case report. And I think both are eminently publishable. And mostly descriptive and analytics, which I think lowers the bar a little bit in terms of some of the statistics required. And so I think it's something that most of us as clinicians can endeavor to put together when we're seeing a group of cases that's presenting itself.
Thank you very much. So as we move on, like our students have this issue that since it's a unique feature or something specific, we get to see, which probably we want to, send a message that, okay, this thing can occur in this particular disorder. Or so my next question to Dr. Shanu Gupta would be that how do I identify, or how does my postgraduate identify that this is the case which I would like to present and then publish as a case report? So what are the unique features, or what are the ways in which, what are the identification, how does he realize that, yes, this is something different and I would like to report this? Could you give some, throw some light on that fact? Because many a times we keep on coming across so many patients, but then what should be reported and what should not be reported? Something about that, Dr. Shanu.
Yeah, absolutely. So the first thing I'll say is that every article has a home somewhere. So you can always find a home for any type of case report that you do want to present. And one thing that I want to just briefly mention is that Lauren and I actually met because we both are associate editors for a newsletter that accompanies one of our societies. So the Society of General Internal Medicine, a little bit like ACP, which is another one of my professional homes, is a professional home for those of us that are in general internal medicine. And our newsletter provides opportunities for people to publish a variety of things, including case reports. And so that's where our interest kind of gathered over the last few years. We've been working together on that. Now, I always start by saying, if you're experiencing real curiosity about a case, if you're spending a great deal of time thinking about a patient you're caring for, if you've got interesting clinical questions that you're diving deep into, that's probably worth publishing somewhere. Other people are probably thinking similarly. And as Lauren mentioned earlier, you can really have cases that can be either novel, like in COVID-19, we discovered a novel virus that was presenting in a weird and interesting way. Or you can have a known disease process that's presenting in a novel way. Or you can have a known disease that's presenting in a similar way that maybe you need to think about as a clinical reasoning exercise in the context in which you exist. So we exist as generalists, and sometimes having a framework. So, here we talked about, Dr. Prabhu talked about a strongyloides hyperinfection that occurred as a result of giving a drug that we use very commonly, perhaps the steroids, the high-dose steroids. So instead of thinking about being careful when you're giving steroids, maybe thinking about how do you think about when someone worsens when you have steroids, right? That would be a really interesting exercise to do, a really interesting framework to create that you could use the next time you have a patient. Not every patient that reacts poorly to steroids is going to have strongyloides, but you may see many more patients who react poorly to steroids. So, if you're having some tensions where you're having to do some deep dives, that's a great place to start. And then think about what your learning objective would be. So if you were someone who wanted to read this case, what would you want to learn out of it? And so if you've got a curiosity, you've got a clear learning objective, that's a great place to start, and then start putting that together, and then find a mentor who's willing to work with you. And that could easily be the attending or consulting physician you're working with, or a professor in the med school or in your residency program that can help support you.
Yeah, that's very true. So after we select as to a particular case, coming to a technical aspect, Dr. Lauren, that patient identification markers, patient de-identification and consent. So consent, do we need to, what sort of a consent we need to have, and how should we de-identify the patient? Because that is something which our students need to know very well. Usually they think it's fair enough, you can put in a picture, you can put in something, but then we have to take the consent, the permission from the required persons. So Dr. Lauren Block, what would you like to say about this? Kindly put your ideas about this.
Yeah, absolutely. I think thinking about ethics is really critical here, right? So I think wherever possible, regardless of consent, I think it's very important to consider anonymity. And I think we can do this by making sure that anything that we're using is not identifiable. So even thinking about any photos, is there a way to de-identify those? If any of the imaging that we're using has any patient identifiers, how can we, hide those from view? If there's anything identifying about the patient, is there a way to zoom in or crop the photo so that the photo is no longer identifiable and relatable to that patient? I think then from there, informed consent for the patient, I think, has to be handled delicately. And, in my experience, when I've approached patients, I think my patients have been really happy that their struggles and some of the toughest parts of their life that they've had to deal with these medical concerns can ultimately be used to help others. And so I think, I use it as relationship building that I've learned from you and from, engaging in this patient-physician relationship with you. And I'd love to learn further, but also bring this knowledge to others. And so I think, where that's possible, I think that goes a long way. Certainly if there's anything that is identifiable, that all has to be documented and discussed with the ethics team at your own institution. The other piece of this I'd say is regarding photos and images. And, we try to talk with our trainees and make this a learning opportunity to say, we should never be taking photos of our patients, right? If anything, any images should be shared with us by the patient or be taken with a health system device or camera, or we should use an image that's already been captured or a piece of pathology like Dr. Prabhu did. So I think it's a really interesting transition to go from a case that we just listened to talking about case reports, because it kind of illustrates this really nicely. But I think from the beginning, we should think about anonymity, we should think about de-identification, we should think about informed consent, and we should think about how these images are required. And avoiding ever taking a photo of the patient with our personal device, but rather thinking about how best in a safe way and in a way that preserves patient integrity and autonomy to obtain some of these images.
Yeah. So it's very important to remove the identifiers and to take an informed consent before we send anything for publication anywhere, if it may be online or any hard copy publication, but informed consent has to be taken. Proceeding further, Dr. Shanu Gupta, once we decide that this is the case, then a good amount of information gathering is essential, the review of literature, and we need to have some information as to how this thing proceeded and how are we unique from the previously done work or previously seen cases. So could you just throw some light on that aspect, Dr. Shanu Gupta?
Yeah, so one of the first steps in any research project, and I think about case reports as a research project, is to see what's already out there, what has already been done around this. And I really like to use my librarians to help me identify the literature that already exists around a particular topic. So if I have a case, not only am I looking up that disease process, but specifically whatever learning objective I've developed as my basic framework for this case, I usually send that over to my librarians, and they will help me identify some literature that may already exist, what has already been written about this case, what has already been learned, and what might be the gap. So that helps me think about what gap I'm filling with the case that I'm wanting to present. And it also helps me think about my own gaps in knowledge, right? So sometimes I have cases that I think are worthy of publication somewhere, and I'll find that actually the learning objective that I was thinking to identify or the gap I was attempting to fill had already been filled. I just hadn't known because I hadn't learned about it or studied about it. But that can certainly help create a new question. And sometimes the case series come from that. You might start off with a case report, and as you do a literature review, you might find other cases that already exist, and that might be a start of a case series for you, right? So, for example, I recently took care of a patient with CJD that we didn't diagnose until postmortem. And we recently had several cases that I heard from colleagues about CJD. And for us, that's an unusual enough disease that maybe at our institution, it's worth writing about because their presentations were so unusual. And even the diagnosis, kind of like what Dr. Prabhu presented earlier, this was a patient that had presented several times to the hospital before we even thought about that disease. And so the question in my mind has been, is there a better way for me to have identified these things earlier so we could have prepared the family earlier, right? So that might be so we are starting a case series of those types of patients that are presented to our institution and what their presentations have looked like and how that may differ from the current literature that exists, or it matches the current literature that it already exists. So yeah, so literature review, literature search is always a starting point for me, because that helps me identify whether even my learning goal is appropriate or if I should be amending that to something higher.
And I think your point, Shanu, can kind of gets to the fact that this can be an interprofessional exercise as well. You mentioned working with librarians. Your discussion of the case series made me think about a case report that I worked on with the pharmacy colleagues, with a patient who developed serotonin syndrome and ended up having a polymorphism in her CYP2D6 enzyme, which a significant portion of the population has. I work with pharmacy colleagues. We were able to actually do her her genotyping and find out that she did indeed have a polymorphism where she was a poor metabolizer of CYP2D6, which then impacted her further treatment for depression and other conditions that she has. And it was actually the pharmacy student who wrote up the case and presented it at a conference. So I think just thinking about who else on your team you can work with, and certainly it could be physician colleagues, but also could be in different fields.
Absolutely. So that's very important point, that information gathering is so important, and it may be from sources which we probably don't realize. It's not only the libraries and the other things, but even many other different people and many other sources which could be there. So that's very important. Thank you very much for your inputs on the on this topic of information gathering. Dr. Lauren, after having said this, the entire format for case report is very different from what our postgraduates usually do when they do any thesis and research on any what it is thesis. It's a original article. So when it comes to writing a case report, they are quite not very aware of it. So could you just elaborate on the format, the basic structure, as how do I go on to write a case report, the basic structure which is there?
Absolutely. And to do so, I thought it would be helpful just to share a slide that Chanu and I had put together on how these may be different at conferences versus when published. I think, if you're going for conferences and there may be hundreds of posters in a large hall, it's important to think about an eye-catching title. The abstracts are often limited to about 500 words. You do have a little bit more time, but it's also important to be concise because that's what's going to be reviewed for acceptance to the conference. As Shana mentioned, important to think about your learning objectives, summarize the case, including the discussion, as Dr. Prabhu did in a succinct but engaging manner, and then come up with your key teaching points, which you want learners to take home. References aren't really as important with conference presentations versus with publications. You want more of a descriptive title so that your audience can find it within the published literature. The abstract is often structured and much more limited in scope. You want to introduce learning objectives, but also the problem and what some of the findings were, what exists in the literature, and where the gap in knowledge may be that would be aided by your case. You do have a little bit more discussion time within the sort of meat of your case to talk about some of the diagnostic and therapeutic factors, as well as the outcome of the case. Still important to have some key take-home points for your audience, and typically references are somewhat limited to less than 15. So much shorter format typically than a research publication. And it's important to think about when transitioning from a conference proceeding to a publication, how some of the formatting may differ.
Yeah, so exactly. Moving on from this further, Dr. Shanu, as Dr. Lawrence said, the title of the case, the title becomes very important, especially even if you want to present in the conference or you send it for publication. If it's an interesting title, somehow I think there are greater chances for it being, looked into and taken up more seriously. So what would you suggest? Any idea as to anything specific which has to be done, or what do we do when do we want to select the title? How do we put the title for a particular case report? Could you say something on that?
Yeah, I think as Lauren shared earlier, a title for something that's a manuscript that's going to be published, first of all, make sure to review the journal guidelines as to how many words, how many characters. Each of those things will have a certain amount of space limitations, so do take a look at that first. And then the title for something that's going to be submitted as a manuscript should be descriptive. So in the case that Dr. Prabhu presented, for example, I would want to know about the strongyloides. I would want to know about hyperinfection probably in the title, because I think that affects my ability to to understand. When I'm busy, I've got 15 tables of content coming through every month in my email or a bunch of different journals. If I'm going to read something, I need to know what I have to prioritize my time as to what I'm going to read. So if the title kind of explains to me what I would want to learn about, that will be really helpful. However, if he's presenting that abstract at a conference, he may have an interesting name that plays on words or is something fun. We did a case on an interesting rash, a patient that presented with a rash, and I think we called it something like a rash decision, and then had something descriptive after that about it, and that was really helpful. That was eye-catching enough for people to remember and talk about, and then we created some frameworks that they could take home with them and use again next time they see a patient with a rash. So I think it does depend on what your audience is, who your audience is, and what you're wanting to get out of it. Are you wanting to catch someone's attention, or are you wanting them to know the content so that they can prioritize their time? And when you're doing a literature search, if you're thinking about when you're typing into PubMed, the questions you're looking for, that's where those titles become important too.
So that's very important point that you have raised. And yes, definitely that has to be taken into consideration. Thank you so much. Dr. Lauren, talking about the conclusion, when we make the entire case report, we try to send some message to the through the report that we are doing. So anything in particular you would like to comment regarding the conclusion? Because I think that would be very important when we talk about a case report.
Yes, absolutely. So I think, the conclusion gives you an opportunity to summarize the case as a whole, and put the pieces together as we typically do in our oral presentations. Is particularly, I try to discuss with learners that there's truth, but there's also weaving the narrative as per the diagnosis and the management strategy that you would recommend as the treating clinician. And so you have the opportunity to kind of weave together the different pieces of the history, the physical, perhaps even some of the epidemiology, some of the objective findings, and then your assessment and plan into one sort of consistent narrative. And then I think it's important to go back to your learning objectives and think about how this case can help to illustrate some of your learning objectives, add to and contextualize within some of the existing data that you've uncovered through your literature review. So how does this confirm or refute or add to the knowledge of this particular condition, diagnostic or management strategy? And then what, if any, gaps remain, what limitations there may be within your case or unsolved questions that you weren't able to answer, like Dr. Prabhu sort of illustrated with the case that he just presented. And then I think you have the opportunity at the end to give your take-home point one more time for your audience, so that if people, skip towards the end, they have the sort of take-home point or just refreshed about it one more time before they finish reading your piece.
Very true. Thank you very much for that input. Another important thing regarding case reports, which is different from the original articles and the rest of the articles that we write, is the abstract. So, Dr. Shanu, would you like to throw some light on as to how the abstract structuring occurs when we write a case report?
Yeah, so a case report is typically not it's not going to have the same content that most other research reports would. There is no methodology specifically that you're talking about. There are no results that you're talking about. So often the abstract is kind of clumped into one narrative that will be a brief introduction of why this case is important to be presented to the world, what the content of the case is, what was the learning from that case, and what is something that you as the author are going to be taking forward to your future patients that the reader may also want to emulate. So it can be very brief. And again, the abstract really depends on if you're submitting the case vignette to a conference for a poster versus a manuscript for a publication in a journal. And again, please review the journal guidelines for case reports. Generally, they're much looser. Generally, it's easier. But I think for someone who reviews and is on an editorial board for a couple of places, if an author has not reviewed our guidance, it can make it very challenging for us to to move forward with that submission. So save yourself some time, save your editor some time, look at the guidance. But generally for case reports, it's pretty simple. It's pretty straightforward narrative.
Thank you very much. Another important technical aspect, Dr. Lauren, I would like to ask you is regarding the Institutional Research Board. Is the Institutional Research Board approval required before we go in for publishing any case reports? And another aspect is that if there is a case series, so is there any difference in that? Do we require an approval from our institute before we go in to publish any case report or say the case series? Because that usually confuses many of the students. So could you like to say some clarifications on that point?
Yeah, absolutely. So IRB approval is required for any sort of human subjects research. Typically, case reports and case series do not meet the criteria of human subjects research because there's no sort of systematic investigation. You're merely reporting descriptively what happened. And so typically IRB approval is not required. Obviously, the guidelines at each institution can vary, particularly when a deceased individual is the subject of a case report, and there may be specific policy specific to the institution. Also, as you're submitting to the journals may require some sort of a statement from the institutional review board. And so that may be a reason with any publication that you may be asked to provide a letter from your IRB saying that this is exempt or does not meet the specifications of human subjects research. But typically case reports are not subject to IRB approval because they do not constitute human subjects research.
Okay, so as Dr. Shanu, you previously also mentioned that we have to keep in mind the journal where we are going to publish it. So what are the points we should keep in mind, while selecting the journal? Because many a times it happens that we have an interesting case, probably we send it to the wrong place, and probably it doesn't meet the audience that is required, and sometimes it may be too simple for that particular journal, and maybe it's rejected, whereas it may not be in the other one. So any points to be kept in mind which our students should look into before they send to a specific journal? So Dr. Shanu Gupta?
Yeah, so it sort of depends on what the case is. If it is a case that is being evaluated in a general medical clinic or inpatient unit ward, there are general internal medicine associated journals that would be very willing to consider a case. It can also be helpful to look at that journal and see what kind of cases they've accepted in the past. And again, if you look at the author guidelines, they will give you a sense of what types of things they're interested in accepting and publishing. If it's a specialized case, there are many specialty journals out there as well. So if it is a cardiology case, an infectious disease case, an immunological concern that you're looking at, just going back to Dr. Prabhu's case, he had so many potential options there, then it might be worth thinking about one of those journals to see if they have an interest. Sometimes if there's a case that has a particular picture that's interesting. So Dr. Prabhu did a great job of incorporating the images that were associated with this patient's diagnostic pathology. So sometimes if it's an images case that's very valuable, then there are journals that will accept an images in clinical medicine submission as well. So there's a variety of places where you can submit things like this. If it's more of a clinical reasoning exercise that you want to work through, then actually that opens up more doors even, in my opinion, where you can submit cases for learning purposes. And then there are some websites that you can use. The one that we talk about in our workshop is called Jane, J-A-N-E. If you just Google Jane journal search engine, you can actually just type in the title that you're intending or copy and paste your abstract into it, and it'll give you a suggestion for different types of, this is what it looks like, journal author name estimator. So if you insert your title or your abstract into that box in that website, it'll give you suggestions for a variety of different journals that you may not have thought of. Once I start looking at those titles, I'll usually go to those journal websites and take a look at the author guidelines. The other thing I tend to look at is whether it's an open access journal or not. Some institutions have connections with open access journals, so you can submit to them. If you don't, there are significant costs involved with open access journals. And for a case report that one of my students was trying to submit to an open access journal recently, and the cost was somewhere in the $700 range. And I do not have that money in my back pocket to throw out for a case report. And certainly my department would be particularly upset with me if I did that for a case report. So those are things that you do have to think about. Yeah, so those are things I would look at. And then the other thing I want to mention is if you do get a rejection either directly from the editor's desk or a rejection from a peer reviewer, I think of that as a really important learning point. That's not necessarily a sign of failure. Sometimes you get things back from an editor's desk with some suggestions. So most editors will provide you with suggestions. We do not accept things like this here. You may want to try such and such journal. And many journals now are associated with a bigger publishing house, and they may have other suggestions for journals that would accept them that can go directly in. So sometimes I've done that. Yeah, so there's a variety of ways of getting into it. And I think that's why having a good mentor helps, who may have been through these rejections before. I've been through many rejections in my life, personally and professionally, but they've always been learning points. And I find it a really valuable conversation to have with my learner if I get a rejection. And certainly if there's some feedback that comes along with it, that can be really valuable. And I always make sure to incorporate that feedback before I resubmit that manuscript to a different place. Do not ignore the feedback that you get from your reviewers or from the editor, because that can be incredibly pivotal in helping you be successful even at a different journal.
Yeah, that would be very important. And that's especially a very important learning point for us, where we can improvise and then do a better job at the next place. So exactly moving on to that, Dr. Lauren, what about the cost of publications? What we talk about case reports, is it free, or as Dr. Shanu was saying, that do we need to pay? What any of you would want to comment on that?
Yeah, absolutely.
Yeah,
absolutely.
As expensive as the rest of the original articles for publication.
Yeah, so I would say always the goal is to publish in a journal that does not have a fee. And I always try to work with, learners or anyone that I'm working with to identify like a really a succession of journals from maybe your reach, where you'd start with, you don't think there's a high pretest probability of publication there, but maybe think, hey, wouldn't it be great? And at least hopefully we will get some feedback, which we can incorporate. I think it can also, doing this a few times, you can get some experience with which journals get back to you very quickly, and which journals may take a long time. And you may want to submit to a journal where you're going to get some quick feedback and a quick response. And then I think one of the limiting factors can be just formatting for a different journal, but certainly using Jane and using some of the other databases that are out there to find out which journals do not have a fee associated, I think is generally the way that I try to go. And then, sometimes there is sort of an optional fee if you want this to be open access, and then you can decide with your team if you have the funding or not. Certainly if you don't have a funded project or grant funding, it can be a lot more difficult. And I have been part of publications where there has been institutional funding to get something published that has a fee, but certainly the first, second, and third choices are always the journals that do not have a fee. And if you're ever not sure, I think this is a great place to contact your librarians to say, is this a reasonable journal choice? What things do I have to keep in mind? Because they can be aware of predatory journals and some journals that you can avoid. And as Shanu mentioned, there can be a home for every article out there. Some of them may be more geared towards subspecialty versus generalist journals. Sometimes you may even think about, is there a non-peer reviewed option? Like we work with the SGIP Forum, which publishes case series, which is not peer reviewed, but still widely circulated. So I think even if you face a number of rejections, like Shanu mentioned, it's important to never give up and think about what other options are available to get your message out there.
Absolutely. So we had some real, vital information regarding writing a case report, which is so important. I request both the speakers, if anything we have left out in our discussion, which you would like to speak upon, I would welcome you. If any point has not been covered, because this has been a very interesting discussion, and I think most of the points I tried to look into, but any other important comment or input that you would like to give to our researchers regarding this case report writing, Dr. Lauren?
Sure. So this is something that we try to incorporate into our resident teaching. So we actually had a session prior to this morning where we ask all the residents to work in teams to kind of emphasize that this is really a team building activity, that each group of residents is responsible for presenting a case in resident rounds once a year. And this then can serve as the fodder for a later case presentation at a conference or even a publication. So I think, it can bring a nice way to do some engaging teachers, put residents or other trainees at the forefront of the teaching, and help mentor learners to do this in a team-based format.
Thank you so much. Dr. Shanu Gupta, you would like to give any important message to our listeners, to our audience, any concluding remarks regarding the case report writing, which is very important for them?
Yeah, I want to just say case reports are fun to write. It's, for us in internal medicine, we love geeking out on, interesting cases. So they're actually really fun to write. And it's really fun. It's a really fun form of self-reflection, actually, on how your practice was for your patient. Where were some things that you could improve on for the next time you care for a patient that presents in a similar fashion? And it's really fun to mentor juniors through that case as well. So I often go through many revisions of a case before we finally submit it somewhere with my trainees. And I really enjoy that process of getting to know my trainee or my junior faculty member, seeing them succeed when they go and present that case somewhere or get it published somewhere. And none of us start off as experts. The first time I mentored somebody doing this, it took me a while to get to a point that was comfortable and looked good. And I don't know that I would call myself an expert now. I'm still in practice. I'm still learning. But it's certainly been an interesting journey to do these case reports overall. And I can't speak enough about how important it is to mentor juniors along in their career pathways. And also to be mentored, I think, to create that relationship with those that are senior to us and learn from their clinical practice can be really helpful. And even though this is, again, just a case report, the practice of writing, the practice of coming up with learning objectives can actually be useful for all types of articles. So that can sometimes be a jumping off point for folks who are then going on to do maybe case series or maybe even getting into clinical trials or something of that nature. But that practice of writing something can be very valuable for your own individual cognitive process, but also for scholarly productivity in the long run. So I appreciate you giving us the time to talk about something that we really enjoy doing in our spare time and I think is really valuable. And as Dr. Prabhu showed earlier, it can be such a great way to be stimulated intellectually.
Absolutely. Thank you so much for such an informative session. I really thank both the speakers, both the panelists, experts, Dr. Lauren Block and Dr. Shanu Gupta, for giving us such a clear view. You have clarified all our doubts, made it, we have realized that it's so interesting. It's so important for the mentor as well as for the mentee. So I think case reports are a very important part of research, and they have to be looked into seriously and encouraged by our students as well as for the mentors. Thank you very much once again for joining at this time. I request Dr. Anuj Maheshwari sir to please give his expert comments on this wonderful panel discussion.
I think there is nothing like expert comment before the experts. You all are the experts, and you have already given the experts comment. But I agree, Dr. Swati, with your one point that case report is the most important part of the medical research, because this is the beginning step for our undergraduate, especially MBBS student, through which we can make them learn how to write for the journals. And if they have a habit to write for a journal, and it will definitely be replicating when they will be growing in good writing, good paper writing, even in good publications, and we shall be having more and more publication. In India, we are facing this kind of a problem very much, that we are already having so many patients in our hospitals, in our medical colleges, but still documentation and publications are very less as compared to the other parts of the world. So if we really wish to improve that, we need to make them writing. We need to make our student in a habit of writing and in habit of reporting, in habit of documentation of whatever they are seeing in their OPD. And if anything very interesting comes, like Dr. Mukhya Prana Prabhu has gone through such an interesting case, and this kind of the cases are being seen by many of our clinicians, and we ourselves has also seen this kind of the case multiple times in our medical school days. I still remember today I got it just refresh my memory. I have gone through a case which ultimately came out of the Wilson's disease. And Wilson's disease is very rarely picked in our setup, but we could really pick it up, and our professor has also said that you should publish it. But ultimately, in the work pressure and all so many things, we couldn't publish, and we came out of the college. So this thing should not happen. If the people will be in habit of writing, will be start writing from their medical school days, and will keep on continuing in their residency days, then definitely it will be helping them in making a good clinician, good researcher, and we'll also improve our country's status in the research. And I really look forward for the 18th March workshop, which is planned for the medical writing and medical case writing, as well as other kind of varieties of the writing, what you people are going to make it with few of the other speakers. And I shall definitely be attending that. It would be a good learning win for me. And I also think that many a times medical graduate and medical practitioner and even medical teacher keep on learning always till the last minute of his life. So with this message, we should always be keep on learning. Thank you. Thank you for asking me for this comments. Over to Preeti.
I would
Yes,
invite
Amit.
Amit Gupta sir to say a few words.
I think as a ACP India case files, we are very happy for today's program, and all the viewers must have found something new, and they must have learned new things about the case report, as well as the very interesting case presentation by Dr. Prabhu. And we look forward to another episode of ACP India case files next month. I would like to thank Dr. Preeti for organizing all this and taking all the lead. She was the program lead for this ACP India case files. And thanks to Amit especially for setting this up and planning for the next meeting, which is going to be scheduled on the 18th of April. So thank you all the faculties and Dr. Swati, Dr. Prabhu, Dr. Shanu, Dr. Lauren for your valuable time and making this a grand success. Thank you. Over to Dr.
Amit, I would like to suggest you that you should keep today's program on our website also, so that the people, those who have missed this, they can get benefit.
Right, sir. We will do that.
Thank you. Thank you, respected speakers, Dr. Swati Srivastava ma'am, Dr. Anuj Maheshwari sir, Dr. Amit Gupta. We now come to the conclusion of today's session of this ACP case files. Both the sessions were very informative and very interesting with wonderful take-home messages. And I'm sure all of us have been benefited a lot from attending these sessions. So thank you once again. Thank you, sir.
Thank you.
Thank you, ma'am.
Thank you. Bye-bye.
Thank you. Bye.
Thank you. Thank you.